Now, hi everyone, and welcome back to Endoscope Decontamination. So, lecture on high-level disinfection. And, well, I suppose in both ultrasound probes and endoscopes, as I happen to talk to you about both those things, there is one tendency. And while in ultrasound probes, a tendency to slowly but surely move from low-level disinfection to high-level disinfection. In endoscopes, tendency is slowly but surely move from high-level disinfection eventually to sterilization, either sterilization of reusable scopes or use of single-use scopes which are already delivered sterile. But high-level disinfection is still the major method of reprocessing flexible endoscopes. Right, we will go into the lecture. Notes are shared between myself and Jer Colleran, but I will also show a few things from a presentation I was just giving literally 2 days ago in a conference. Also on the same topic, on the movement from high-level disinfection to sterilization of flexible scopes. So I will be sort of jumping between two sets of notes. One is your school sets of notes, and one is my personal, but I am going to share PDF of that one with you as well. That's something I'm using for my own presentations elsewhere, not in the university. Okay, and again, not been in my best shape today, so will be intermittent coughing, sneezing, and all that jazz. But hey, once in a while, you get a bug. It's no big deal. That's life. Anyhow, we go into the lecture proper and straight up to the page one, of course, where we start from. So, disinfection concept. What is disinfection? How do we get rid of microbes with different chemicals? Here, we are not talking about physical disinfection methods. We are not about hot water disinfection as for surgical instruments, not about ultraviolet disinfection, which we have for ultrasound probes. Even though now UV disinfection is also sometimes sold as a method for reprocessing non-lumen scopes such as ENT scopes with no channels, which again is a bit shady area in my opinion, but this is, once there is a technology, it is sort of seeping absolutely everywhere. But we will be talking about chemical disinfectants more than anything else. And the idea is to, well, I suppose to start with difference between disinfection and sterilization. We will talk about which chemicals are used in endoscope reprocessors, do a bit of recap on low, intermediate, high-level disinfection, and then disinfection challenges. So all that is in the next hour or so. Disinfection. What is it? Disinfection is destruction of microbes, but not all microbes. Destruction of pathogenic cells and viruses, but not all bacterial spores. And I suppose this is where we start, because they are going to be survivors after the disinfection. Oh, let's jump here. High-level disinfection. So if you validate a high-level disinfection system, you need to prove as an engineer or as a manufacturer that system actually kills microbes to an extent. Now, how much is that? That's a different question. Because if you go by definition that high-level disinfection is complete elimination of all microorganisms in or on an instrument except for a small number of bacterial spores. I genuinely have a problem with this word, small, except for small numbers, because this is not something you can validate. You cannot validate a small number, and a small number for you may be 10, small number for me may be 1 or 100, like who knows? So that is not something you would use in validation, of course. Now, they are criteria, they are standards for a process or a chemical to be classified as a disinfectant. For example, FDA, Food and Drug Administration in the States, define high-level disinfection is a sterilant. So, high-level disinfection to some level is compatible with sterilization, comparable with sterilization. But sterilant used for a shorter contact time to achieve a 6-log kill of appropriate mycobacterium species. Bring down number of mycobacteria 1,000,000 times. Kind of sounds familiar to sterility assurance level, doesn't it? But the big difference here is that all you have to do to validate that process is to make sure your numbers have come down 1,000,000 times. And if you start with a trillion microorganisms, on a scope and you put it dirty in the endoscope reprocessor, it will bring numbers down 1,000,000 times from trillion to 1,000,000. And we have million survivors at the end of the process, which technically meet the criteria for high-level disinfection. Like, it's obvious nonsense, of course. So efficiency of high-level disinfection depends on two things. How much contamination, how much bacteria was present on an instrument before the start of the process, and how successful was the cleaning. Because if we don't want any survivors, we would need to ensure we go into high-level disinfection with a total numbers on an instrument of preferably less than 1,000,000, when we are in relatively safe area. But there is more. There is more to that, and we will actually come to that story again in ultrasound probe class. This is a picture from an ultrasound probe lecture you will see later on. But this is a very telling one. It shows you types of tests done by the manufacturer to prove that their system actually provides high-level disinfection. There is a mixture of American standards, ASTMs, and international standards, ENs. But so, after a brief technical interruption, my connection is back. And what level of microbe reduction is necessary for a process to be certified as high-level disinfection? And okay, we mentioned already, according to the FDA, mycobacteria 1,000,000 times, so 6 log 10. Here we have it. What else? Bacteria, growing bacteria, your E. coli, your Staphylococcus, your Streptococcus, Enterococcus, you name it. Again, 1,000,000 times or more. Happy days. Spores. Does that high-level disinfection kill spores? It does. What is the small number? We don't know, but we need to kill 1,000,000 spores at least. Happy days. So almost in the sterilization territory. But here is the but. Fungi. 5 log reduction. 100,000 times, not 1,000,000 times. And once you go into technical details of standards, you are into interesting information. Viruses. polyomavirus, adenovirus, HPV, vaginal herpes, norovirus, a bunch of viruses. 10,000 times only. Not 6 log reduction, 4 log reduction. And you have these parameters met, you have passed your high-level disinfection. In sterilization, we don't allow survivors. Okay, we can talk long and hard about sterility assurance level and all that, but in practical terms, if you have a survivor after sterilization process, your process has failed. In high-level disinfection, if you have a survivor after high disinfection process, your process may be passed. That's the major difference between the two. Talking of margin of safety for a patient is, of course, greater than in sterilization compared with high-level disinfection. I honestly think this is an important difference between the two processes. So I wanted to bring this up. So disinfection, we can employ different methods, and this time we are talking about not filtration, not radiation. It's all done and dusted. We have spoken about that to the end of the world and back again. Chemical, either liquid or gaseous. Now, what's the difference between liquids and gases, and what's the story with high-level disinfection with chemicals anyway? It is not terminal disinfection. Like for sterilization, what do we have there? Once something is sterilized, it is normally wrapped during sterilization, unless we are talking about flush sterilization in the OR, isn't it? So if we have something sterilized, it is wrapped and it can sit on the shelf for days, months, maybe even years, depending on specifications of the packaging. Endoscopes, as soon as they are out of an AER, they will become recontaminated with environmental microorganisms. All the microorganisms we are shedding from the personal belongings, from hair, from PPE, from the hands, you know all that. You have all been to the workshops, or you have seen the workshops in microbiology. The point is, high-level disinfection, after it is finished, after the scope is rinsed with a purified water from the residual chemicals, that's another thing. You need to get rid of all the chemicals so you don't cause any damage to a patient or to healthcare workers. So you need to rinse. What do we rinse with? RO water. How much bacteria we can have in the RO water? Well, ideally below 10 CFUs per 100 ml, but it is still kind of acceptable. We are in the orange level up to 100 CFUs per 100 ml, 1 bag per milliliter. So we are essentially recontaminating the scopes by rinsing them in purified water, if it is not purified to the highest standard possible. And then those introduced survivors, if there is residual moisture in the scope channels, they will start growing, and in a couple of hours, what do we get? We get biofilm forming. So endoscopes are the cleanest immediately, the moment they are, well, not even when they are removed from the AER. Now this one is tweaking the truth a little bit. They are the cleanest immediately after they are high-level disinfected. Then they are rinsed, and then they are removed from the AER, and that's they become recontaminated, and that's why we have a 3-hour rule. Unless endoscope goes into a drying cabinet, is hooked up to HEPA filtered air, we make sure that there is no residual moisture in scope channels, then it can hang into the drying cabinet for the duration of time that drying cabinet is validated for. Still, it's not indefinite. We are talking of hours, maybe week at most. There are other storage systems on the market, like I think it's Plasma Typhoon and Sure Store, when endoscopes are flushed with some extra disinfectant, like with ozone. They are vacuum packed, they are dried, and they can sit in the vacuum pack for extended period of time, but that period of time is shorter than sterilization anyway. Right, so that That is again an important point about high-level disinfection. As soon as it is done, instruments are recontaminated again. In sterilization, if we have instruments wrapped, that is terminal. Terminal sterilization, instruments are going to stay sterile until that package is opened. Already two important differences between high-level disinfection and sterilization. But all we do there, we kill microbes. That's why time and concentration of disinfectant and disinfectant chemistry are really important, again, for successful process. Because your manufacturer of any disinfectant will have validated that disinfectant to work on an instrument for a certain period of time. To bring down those numbers a million times. Well, let's stick with a million times here. And they have calculated that time based on knowing microorganisms. Here, for example, let me just jump back to that. Oh, they have calculated killing times for Salmonella, for Staphylococcus, for Pseudomonas, Escherichia coli, Enterococcus, Klebsiella, for all of them. Instruments were inoculated, seeded with bacteria, and exposed to high-level disinfectant, so that at the end of the process, numbers do actually come down the same million times. And what is used in the validation, that concept of decimal reduction time, and I believe Dermot Morley would have told you all about that in his series on validation. So just a brief recap. Decimal reduction time, it's time needed to kill 9 in 10 microorganisms. Or, in other words, to kill 90% of the population. As with microorganisms, again, don't ask me why. I'm actually genuinely perplexed about that. It may be individual variability of microbes or individual vulnerability, rather, but they don't die all at once when you apply your sterilant or your disinfectant. And for starters, maybe they may not all be exposed to the disinfectant straight away. But anyhow, once we know the decimal reduction time, let's say it is, what is it here, 15 minutes, 90% reduction or killing of 9 in 10, it gives us 1 log reduction. So bringing something down 10 times, it's 1 log reduction. And that is the parameter of a certain chemical at a certain concentration. We have to give it a concentration and a temperature and a specific microorganism. So decimal reduction time for E. coli will be different from decimal reduction time for mycobacteria and for spores of Geobacillus stereotrimophilus. So it's individual value based for exact temperature, exact concentration of disinfectant, and nature of microorganism. So at the end, we need to achieve a million times reduction, or 6 logs. So we go through 1 D value, we reduce population by 90%. Next, same period of time, we'll reduce the survivor by another 90%. So we end up with 1 in 100. One more D value, we end up in 1 in 1,000, and so on and so forth. But the reduction graph is straight down sloped. Well, it's not a curve, it's a graph. Straight and downward slope on the numbers of microorganisms. Every next D value, we have another 90% gone. And for the high-level disinfection, we need to, let's say, reduce numbers a million times. Once again, cleaning is absolutely vital before disinfection, because the more you start with, the more will be left after the time has passed. And surgical instruments in CSSD, they normally have much less contamination compared with used flexible endoscopes, which is logical. For a surgical instrument, it's used in a sterile area of a body. It will be contaminated with blood, with bodily fluids, with human cells. If it is an abdominal surgery, it may be contaminated with gut content, all right. but mostly it is contamination with human soil, so to speak. Few bacteria will be there from the skin, from the environment, and if you leave those instruments unattended for a period of time, of course, those bacteria, they will start to grow. They will get more and more. But that is nothing compared with endoscopes. Because on a surgical instrument, you have a couple of hundred microbes, normally before they go into the washer. For the scope, which has just come out of somebody's bowels, we are talking billions, trillions of microbes in the scopes and on the scopes. They are much more heavily contaminated. Plus instruments, even if they are lumen instruments, they are relatively easy to clean compared with long, narrow, winding channels of a flexible endoscopes, which are jam-packed with microorganisms after use. That's the big challenge. And that's why endoscopic procedures were considered the highest risk procedures for spreading infectious agents from one person to another. Because we start off with the highest possible concentration of microbes, and we have very challenging instrument, which is reused many times, which is brushed, leak tested, and whatnot. And you remember, of course, that plastics, after repeated brushing, they do develop microscopic defects, which allow for biofilm attachment and growth. Plus, not only bacteria we have in the endoscopes, we will have mucus, we will have body fluids, we will have loads and loads of organic matter on a large surface area, which is relatively inaccessible. Plus, we cannot sterilize them using heat. Technology is not compatible there. All that combines together, and that's why we get much more reports on patients being infected with endoscopes compared to the patients infected with surgical instruments. That's again the reality of life. And as we are dealing now with more and more people who are elderly, who have multiple, what they say, comorbidities, multiple health issues altogether, the immune system is not so good anymore, and when we are using some sort of a substandard reprocessing technique, that is a problem. And there is a number of reports of infection transmissions, for starters. Just here, it's from 2013. This is a bit of an old story, but a lot of outbreaks reported in the States, because they, compared to us, I suppose they have at least a tad better reporting system from all types of endoscopes: upper GI, colonoscopy, ERCP, bronchoscopy. And as you see, bronchoscopy is one of the top troublemakers here. And microorganisms have been coming from cleaning and disinfection, from water bottles, from endoscope washer, from all possible sources. And total number of patients infected, well, they do measure in hundreds and thousands eventually. And you can say, okay, it was so long ago, 12 years ago, 2013, surely things are better by now. Well, I'm afraid not really, because on the topic of bronchoscopes, just go here to the other presentation. Yeah, the same good old US FDA, Food and Drug Administration. Now, what do they do? Between 2010 and 2021, so this is a bit more recent, they received almost 1,000 reports related to infections or instrument contamination with reusable flexible bronchoscopes. This is an ongoing story. Like, we know that bronchoscopes, they are risk factor for transmitting especially mycobacteria. We know that people get infected, we know that people die, because among those 1,000 reports of infections, 7 people actually died as a result of those infections. And FDA, after analyzing the report, recommends for reusable bronchoscopes to consider using sterilization instead of high-level disinfection when feasible. Again, that very vague sort of language. Like, if you can, if it is not too much bother, would you please sterilize that scope? But if it is too burdensome, if you really have to try too much, forget about it. That's the nature of recommendations. They are not really mandatory in this sort of language. Even though After that, FDA, quote unquote, says sterilization has a greater safety margin than high-level disinfection. And on top of that, they say, yeah, you have to do all the cleaning part properly, using only manufacturer-specified cleaning accessories, disinfectants, cleaning agents, detergents, and whatnot. But we are still there. And just another study here. Effectiveness of reprocessing for flexible bronchoscopes and endobronchial ultrasound bronchoscopes. Clinical study back in 2018, also relatively recent. 24 scopes examined. All of them, of course, they were contaminated immediately after use. This is no surprise. But microbes grew, including pathogenic microbes. They grew in more than a half of high-level disinfected scopes, even when those scopes were reprocessed following reprocessing guidelines by the book. It still didn't stop bacteria from surviving, which I suppose just highlights that message that high-level disinfection is not about removing all of microorganisms. It can be validated with survivors still present. That's why cleaning is the most important here. We need to remove all the organic soils, and we need to reduce numbers of microbes as much as possible before disinfection. Soils, what they do, if they expose to disinfectants, they can be baked to the surface. They can protect, like a thin film, protective film, they can protect microbes underneath. They can chemically react with disinfectants, neutralize disinfectants, because of course disinfectant doesn't care like which molecule it has to work on. It can be molecule in bacteria or can be molecule in a mucus, it doesn't care. And if there is more mucus around, it will go for mucus, of course. Plus, as we mentioned, soil can be literally chemically bound to the instruments. And then it will be very difficult to remove that soil in washing, in the manual clean and in the automated clean. So cleaning is the single most important stage in the entire decontamination process. That's the message here. And majority of endoscopes are not thermally, and I would say /terminally sterilized. They are disinfected using liquid chemicals which flow through endoscope channels. Some scopes, they are now getting sterilized once in a while or for particular patients, or like in moment, for example, all the ENT scopes are now sterilized. But GI scopes, colonoscopes, duodenoscopes, and so on, they are not sterilized at present. There are some developments in low temp sterilization which will eventually allow us to sterilize GI scopes. But those developments are not compatible with existing scopes. Basically, what does it mean? If you want to sterilize a GI scope in low temp sterilization, you will have to buy a new GI scope which is compatible with low temperature sterilization. You wouldn't be able to use your old scopes for that. Right. So not thermally sterilized. Low temperature sterilization, we spoke about that a lot last semester. Most common one would be hydrogen peroxide. There are companies like Matachana which are making sterilizers using low temperature steam and formaldehyde. Also effective for GI scopes, although cycle times are long, and you need a lot of rinsing and flushing of chemicals to make sure scopes are actually safe for the patients. Right, so there are some developments, but they are very limited. In most of the scopes, they are still, of course, disinfected. Some microbes will survive the processes, depending on disinfection level. The lower the disinfection level, the more survivors we have. And this is, again, something very familiar to you, from least resistant to most resistant. Bacterial spores, killed all of them by sterilization, mycobacteria, high-level disinfection, and when we are talking about vegetative bacteria and viruses, then it is low and intermediate, although HPV and norovirus, they can survive intermediate, low, and to some extent even high-level disinfection. So there is a bit of contention there again. So 3 levels. Low level. On non-critical items, on floors, tabletops, surfaces, your disinfectant wipes with quads. Medium or intermediate, it's more really of American thing. Disinfection which destroys bacteria, viruses, most fungi, but not spores and not necessarily mycobacteria. High level disinfection is what we are talking about today. And endoscopes which go into sterile regions of the body, they have to be sterile, which is actually recognized by the regulators in the same vague sort of language. Let's have a look here. For example, British Society of Gastroenterology, that's the one. Procedures that breaches gut mucosa and is followed by the withdrawal of an accessory through the working channel of an endoscope is deemed invasive. Okay, what's that? No, this is what's that. Polypectomy. Procedure which breaches gut mucosa as we see it here, risks bleeding after that polyp is cut off. And you can say, yeah, fair enough, but what if I use diathermy? What if I do electrocoagulation? It will not be bleeding, but nevertheless that mucosa is breached and there is a wound. Our gut is moving all the time. Peristaltic movements, they are not stopping. So you have a wound on a surface which is constantly on the move. So even when it is cauterized, it will come undone to some extent. And it will be open to contamination. Again, you will say, so what? Gut interior is not sterile anyway. There are trillions of bugs in there. So what does it matter if you bring a few of them on the scope? Yeah. The thing is, for your immune system is familiar with your own microbiota, with your own microorganisms. You have lived together with them for a decade. You know more or less how to deal with them. But what if, on top of what you already have, we have some pathogenic microorganism, maybe C. diff spores introduced with a scope from somebody else? And when this loop used for polypectomy, the snare, how does it go in? It goes in through the biopsy channel, and it is single use, it's sterile, happy days. But as soon as we open it, as soon as we push it into the endoscope channel, it is contaminated straight away because it's not going through a sterile environment all the way, meter, 1.5 meters, 2 meters, before it emerges, comes out on the other side, and we do something with that. So BSG says single-use accessories should always be used, fair enough, and endoscopes used invasively, for example, for natural orifice transluminal endoscopic surgery, should be sterilized using a validated compatible sterilization process, and high-level disinfection is not sufficient. Quote unquote from the BSG guideline. And still, we high-level disinfect the GI scopes simply because there is no other viable option. But that realization is slowly but surely creeping up. That's why I was saying, for the ultrasound probes, we are slowly but surely moving on to the high-level disinfection from a low-level disinfection, and then for the endoscopes, we are moving to sterilization from high-level disinfection, one tiny step at a time. All right, where were we? So 3 levels of disinfection, and those are done according to the Spalding classification of medical devices. So non-critical medical devices require intermediate level disinfection, semi-critical require high level disinfection, and critical requires sterilization. And as soon, in normal logic would be as soon as we have a procedure which breaches mucosal membrane and draws blood, that procedure is critical and everything involved in that procedure has to be sterilized. It kind of makes sense, but common sense and guidelines sometimes they don't really add together. So low-level disinfection doesn't kill spores, doesn't kill mycobacteria. Low-level disinfectants may have added detergents, but they are quite good for killing normal, ordinary vegetative organisms. Staph aureus, Pseudomonas, Salmonella, etc. But low-level disinfectants, as you know, still acceptable on the transcutaneous probes alone. Okay, enough about ultrasound. We are in the scope territory now. Intermediate level disinfectants, not fully sporicidals, more active against mycobacteria, but not completely. And then high level disinfection in defined concentration for defined period of time. Now, I have somebody very attention seeking here. In defined periods of time, dependent on the chemical, of course, it will be individual time for every chemical. They will kill most of microorganisms, leaving a few survivors behind. Now, if you just excuse me a second, I have to put him away. It's too much attention going on. Yep. Off you go. That is now sorted, so perks of working from home. So what chemicals are we using as high-level disinfectants? Glutaraldehyde, OPA, hydrogen peroxide, mixture of hydrogen peroxide and peracetic acid. Hypochlorite will actually also work as high-level disinfectant in these concentrations. So, glutaraldehyde, OPA, H2O2, PAA, hypochlorite. Oh, Sidex. Good old Sidex. Orthophthalaldehyde. It is good. It is actually good on mycobacteria. And new formulation of Sidex actually contains peracetic acid on top of orthophthalaldehyde, which is acceptable. That's fine. Sidex OPA is fine. Sidex plus with glutaraldehyde. Well, that is not actually fine because glutaraldehyde, as you know, is a potent fixative. They are very toxic. Some species of Pseudomonas, biofilm builders, are now resistant to glutaraldehyde. On the flip side, they are not carcinogenic. They can be used to fix slides and tissues for lab analysis. So that already shows that glutaraldehyde can glue proteins to biomolecules to the surface. And we are phasing that out in the EU. Not everywhere in the world, but in the EU, we are phasing out glutaraldehyde. So what happens? We create covalent chemical bonds with a proper strong chains between soil and a surface. Not an ionic bond which can be easily disturbed. Not a weak chemical bond which can be flushed off with RO water. Once you have covalent chemical bond, it cannot be, now that's the thing about covalent bonds, they cannot be destroyed by mechanical action. You have a proper molecular attachment there. So mechanical action is no good, chemical action is no, or thermal action is no good. You would need another set of chemicals to dissolve covalent chemical bonds, which is not actually a dissolution, but proper chemical reaction. That's our glutaraldehydes. They do inactivate microbes very well because they damage critical proteins. They are effective to an extent in presence of soil, but they will fix that soil to the surface. And in France, they are not permitted for endoscope decontamination. If I look into HEC guidelines, they are quite happy with OPA and PAA, but glutaraldehyde is not there either. And then very hazardous to health and to the environment. Because normally what happens with our disinfectants, once they are done in the AER, they are flushed down the drain and the good old solution to pollution is dilution, is what happens. But for glutaraldehyde, any waste has to be disposed of as chemical waste. Oh, why does it jump up, not down? So Sidex, the Sidex OPA, or new Sidex, they are used really almost everywhere in the world. Well, not with Wassenburg, I suppose, because in Ireland here we have very unique situation. we have a monopoly in the HAC, and if you think of it also in the private sector, for endoscope reprocessors. Wassenburg has complete market here in Ireland for endoscope reprocessors. And because everyone has Wassenburg machine, everyone is going to use more or less Wassenburg disinfectant. What do they use? They use PAA, peracetic acid. And that's why Sidexes, different Sidexes, were not so much used for endoscope disinfection in Ireland, because our only supplier of machines is using different chemicals. But you venture out into the UK, you venture out into the big world, and situation will be, of course, different. There will be many different manufacturers of endoscope reprocessors using different chemicals. So what we are using here, it's not the end of the world. There is more out there, and technology is different. So Sidex OPA, 0.55% orthophthaldehyde, works at room temperature in 5 minutes at 25 degrees, 15 minutes at 20 degrees. It is not that much affected by contamination, although we should start with saying that no contamination is allowed on the scope when it goes into the scope washer disinfector. You don't need to pre-mix, it's active straight away when the bottle is opened. And then once you have opened it, you need to use it up during 2 weeks period. And there are tests which you dunk into the OPA, and they change color. If the color change is proper, then OPA solution is still active, because it will slowly break down when the bottle is open. And it is exposed to the air, to the environment. Low smelling, low vapor. So not only the smell is less as such, but the amount of vapors in the air is also less compared to the amount of vapors from the PAA, so to speak. So you are allowed to do the disinfection with Sidex without specialist ventilation. I'd still say it's a very good idea to have that ventilation, to have that air extraction from the dirty side, to have that negative pressure. Because even if it is small concentration of something which you cannot really feel over days and months and years of manual work, it will eventually create trouble to lungs, to skins, to eyes, and so on. Okay, why does it keep jumping to glutaraldehyde? Sidex. We did Sidex. Good against mycobacteria, good high-level disinfection capabilities, and what does it do? It binds to cell membranes and to viruses, and it prevents membrane from functioning properly. So it clogs up the cell membrane. It messes up with uptake of nutrients. It messes up the disposal of waste. So cells do get poisoned in that way. It combines with DNA and RNA, which is important in case of likes of norovirus. Because norovirus naked DNA can still be theoretically infectious when it is lying around. But if it is chemically fused with OPA, it is not infectious anymore. For higher concentrations, for long incubation times, it is sporicidal to an extent, but not really a sterilant as such. Okay, glutaraldehyde again. Peracetic acid. So we have it in new Sidex and we have it in PAA. So it's hydrogen peroxide and peracetic acid. Strong oxidant, quick working, effective against spores. It can be actually used as liquid chemical sterilant. That's a possibility, although liquid chemical sterilization is not recommended anymore in any of our local guidelines. We have really moved away from buckets of sterilants where you just dunk an instrument, leave it there for 20 minutes, for half an hour, then take it out, rinse it off, and use it on the next patient in the OR straight away. We are hopefully away from that situation. Peracetic acid is unstable. It breaks down in presence of air, in bright light, in high temperature. But remember, hydrogen peroxide. It is sensitive to light, it's sensitive to temperature, it's sensitive to oxygen. So same story with peracetic acid. As soon as you have your hydrogen peroxide somewhere, you are into the same chemical problems. So it has to be stored very carefully. It is highly corrosive. And if you are working with PA, you need to have a chemical spill kit. You need to have training on how to handle that chemical in case of spill. Well, in fairness, with all the disinfectants, especially high-level disinfectants, you need to have not only a policy on spills, not only the spill kit, but everyone has to receive training on what to do when spill actually happens. Because it can. Somebody can accidentally knock off a bottle with unscrewed cap, and here you go. You have a puddle of peracetic acid on the floor, and it will attack your eyes and your nose straight away. So after it is expired, it has to be disposed of as hazardous chemical waste or neutralized, and then solution to pollution is dilution. Glutaraldehyde again. So what does it do? It's an oxidant. So it strips away electrons from biomolecules, it destroys membranes, it destroys enzymes, and over a longer period of time, it actually seeps through endospore covers and gets into the endospores proper. So different disinfectants would work on different active sites, mostly. So your cytoplasmic membrane is attacked by peroxides and peracetic acid, so PAA, phenolics, quartz, chlorine dioxide. DNA is mostly by aldehydes, proteins by the combination of nearly everything. And that is another important message in this one. So what's the message? Remember on the ultrasound probes, I mentioned bacteria can develop resistance to disinfectants. And the best microbiological practice would be to change disinfectants once in a while. And here is the scientific rationale. If a bacteria figures out how to protect its DNA from aldehydes, when we have survivors multiplying, we have aldehyde-resistant microorganisms, like Pseudomonas aeruginosa resistant to glutaraldehydes of all things. And then all of a sudden we go for PAA. And instead of DNA, it goes for cytoplasmic membranes and proteins. So previous defense mechanisms are not working. Bacteria survivors need to come up with something new. And that is difficult, that is costly, actually. Because antibiotic and disinfectant resistant bacteria, that's a funny story. They grow slower, and they are normally less virulent, less infectious, compared with non-antibiotic or non-disinfectant resistant microorganisms. Because they spend a lot of their energy running those chemical mechanisms which protect them from disinfectants or from antibiotics. That energy is not unlimited. They don't have a nuclear reactor inside of them. So energy is limited, resources is limited. And if you need to fight some chemicals, you will be less active, you will grow slower, and you will be less invasive. So between MRSA and non-MRSA staphylococcus, usual staphylococcus can cause more severe infections. But why are we concerned about MRSA then? Well, it's because if you have more severe infection with susceptible microorganism, your first line antibiotic treatment is going to work. But if you have weaker infection, but with resistant microorganism, it is more challenging to treat it with a second or third line antibiotics, especially if that infection happens to be in elderly, pregnant, immunocompromised, and so on. So changing disinfectants over a period of time is a good idea from microbiological point of view. But if you do that in your endoscope washer disinfector, that is massive challenge on with validation, with chemical compatibility. Is that my new chemical compatible with AER? Is it compatible with my scopes? How do I revalidate? And if it is Wassenburg, who is happy to sell you the PAA, they may not be so happy if you bring other chemicals from outside and try to validate Wassenburg washer for different chemical. And in fairness, that makes sense because they will have validate their machine for a certain chemical, and that's it, end of story. They wouldn't spend ginormous amount of time and money trying to validate the machine for other chemicals. So that's a reality of life. On the topic of chemical spills, we had one 10 years ago now. Midlands Regional Hospital, Portlaoise. Leak of peracetic acid from an endoscopy machine. 6 members of staff received treatment. So what happens? You spill this aggressive chemical and you evacuate the building. So incident was confined to a localized area in one room of a hospital. That's, well, I don't know if it was a chemical storage room or if it was a dirty site of an EDU. But rescue services, they had to come in gas-tight suits, in breathing apparatus, and then only they could contain the leak and clean up the site. Peracetic acid is highly irritant to the airways. You cannot just breathe air in the room with a spill of PAA. Disposal of high-level disinfectants. Disposal of OPA or glutaraldehyde down the drain is not permitted. Again, if any of you is using OPA in endoscope reprocessors, I would appreciate if you let me know what happens with OPA or Sidex when the cycle is finished. Does it go down the drain, or do you have a separate container for the waste disinfectant? I don't know, because going by the MSDS, by safety datasheet, you shouldn't be allowed to dump Sidex in the sewer. So unused expired disinfectants should be treated as chemical waste, collected by licensed waste contractors, and chemically neutralized off-site. We are neutralizing PAA, unused PAA in the containers, that's fine, but a tiny bit of it remaining at the bottom of a jug. We are not talking about expired full container. That one, you would have to dispose of it properly. Used high-level disinfectant waste should be collected in holding tanks and chemically neutralized prior to removal. I'm not sure if that happens. I'm pretty sure that PAA is diluted and goes down the drain. And in fairness, it is acetic acid and hydrogen peroxide. The moment it flows down the drain, it is going to disintegrate. Hydrogen peroxide degrades into oxygen and water. Acetic acid, it's a natural substance. Okay, it is well, deadly in high concentrations, but in low concentrations, bacteria in the sewage treatment plants will chomp on it happy days. It is a good source of food for microorganisms. So that is, I'd say, mostly relevant to likes of aldehydes and likes of Sidex. So high-level chemical disinfection. Following thorough cleaning is the process which is used to decontaminate most flexible endoscopes nowadays. For disinfectants to work properly, we need strict control of temperature, strict control of time, strict control of disinfectant concentrations, because they have been validated and optimized to work in exact environmental conditions. Disinfection failure can be caused by a residual soil in a scope channel. That's the way it is, because disinfectants can protect microorganisms, or not disinfectants, soil can protect microorganisms, and it also can neutralize disinfectants. Low temperature sterilization processes are coming in slowly, really slowly. Because if you look at the British guidelines, yeah, there is some recognition of low temp. FDA, it gives some recognition to sterilization. But if we just go in here, not in here, in here, European Society of Gastroenterology, some critical devices require cleaning and disinfection with bactericidal, fungicidal, mycobactericidal, and virucidal activity. Sporicidal is not mentioned here at all. No mentions of sporicidal activity. Only flexible scopes used in sterile body cavities, such as the ones in laparoscopic procedures, should be sterile at the point of use. That's fair, very critical. But if that scope breaks mucosal membrane from the inside, so natural orifice transluminal endoscopic surgery, they only have to be freshly reprocessed, whatever it means. So you see the language of guidelines. It's not really I suppose, not really comparable to what we face as a reality nowadays. And yes, there have been reports, or not reports, but calls to revise Spalding classification. It was when Spalding classification was developed, which is like 70, 80 years ago. We didn't know that prions exist. We barely knew biofilms are a thing. We had very little understanding about endospores and non-enveloped viruses. We do know all that now, but it's not reflected in Spalding. Scopes at the time of Spalding, they were only used for observation. Now we use them for interventional procedures. And plus aging population gets more and more vulnerable. And this is the way forward, unfortunately. Population is aging. We have less and less children. And by the time I get to my 80th, hopefully, what is it? 2060. Yeah, by the time it is 2060, we will have very few children. And we will have a lot of old people who are on a lot of medicines with a lot of pre-existing medical conditions. And they will come to the procedures. And if they get contaminated with infectious microorganisms, well, that's the problem of elderly population solved and patient funds saved. But is that what we really want? So calls to revise Spalding classification, they are out there, but again, to be honest, I don't see it's happening anytime soon. Right. On that not so optimistic note, I'd like to finish up today. I will also send you, so I am sending you all the notes, and I am sending you a white paper from one of the medical device manufacturers outlining rationale for moving from high-level disinfection to sterilization, just for your own information. It's quite a good language and quite a good arguments in there. See you online next week for the proper live class. And with that, off I go to fight my own virus.